Can everyone hear me? Okay, great, thank you. Well, it's great to see so many people here, and thank you, Sarah, for organizing, with everyone's help, this symposium. So I'm Rani. I'm a member of the Department of Radiation Oncology at Thomas Jefferson. I'm also a member of the Ocular Melanoma Multidisciplinary Clinic and evaluate patients with the team here for radioactive microspheres and also for treatment of other sites of metastases as well. And we'll mostly be talking about extrahepatic metastases today. So just a little bit of background about radiation, and we're going to talk about this phenomenon of oligometastases, which has really been well defined in sort of more standard melanoma patients as opposed to uveal melanoma patients. I'm going to review stereotactic radiation, which is really the more novel technique now being used to treat metastases, as well as the role of the stereotactic radiation, or SBRT as we call it, for extrahepatic sites. So just as a background for radiation, I know many patients with ocular melanoma receive radiation therapy for treatment of their primary site for either plaque brachytherapy or proton therapy, but in general, about 50% of all cancer patients receive radiation therapy either as part of their curative treatment or for palliation, and it's really part of a combined modality approach to therapy. And I really want to emphasize this combined modality approach. Most of us, we'll be talking about our specific things, but we almost always discuss patients, even for use of SBRT in a multidisciplinary tumor board type situation, or the treatment's usually done in agreement with a group of specialists. None of us are sort of cowboys out there by ourselves. So radiation therapy for metastases is typically considered palliative, and it's typically done over a short period of time. And it's really because the goal is to help symptoms while limiting side effects. But things are changing for some patients. So we're using the principles of what's called stereotactic radiosurgery, which was originally developed for treatment of brain metastases and other sites of the brain, and we've moved those principles to the body. And that principle for the body is called stereotactic body radiation therapy, or SBRT. And again, this phenomenon of oligometastases has really pushed this phenomenon forward as well. And what are oligometastases? And that's the fact that in some patients with few sites of disease and number of metastases, locally aggressive therapy combined with systemic therapy, if available. If it's not available, we tend to be more aggressive with patients with just few sites of metastases because there's really nothing else to offer. So the theory that in this situation, we can improve outcome by being locally aggressive. And that's different from, sort of some other sites of oncology where, if the cancer spread, just chemo only, because chemo can work. If chemo can't work or there's only a couple of sites of disease, it's important to treat the sites that are apparent. And again, this phenomenon was really described and became very popular in the mid-1990s. And again, it's because we can find oligometastases. Imaging is better, and treatment of systemic disease is better. Now, the definition is variable. What is oligometastasis? Some people say up to 5 tumors. Some people may say up to 10. It's all relative. There's no long-term data suggesting a standard of care, so it really depends. People are running clinical trials now determining if treating oligometastases is helpful, and the clinical trials really vary the number of sites. The best data we have now on treatment of oligometastases and treatment of SBRT, or stereotactic radiation, is really on lung and liver metastases. We have newer data on treating spinal metastases, but really all these sites, we extrapolate the data to other areas. So we use SBRT to treat pancreas tumors. We've used it in ocular melanoma patients to treat periportal and peripancreatic lymph node metastases or intra-abdominal metastases as well. Again, what is radiosurgery? So we'll just define this. So the holy grail of radiation therapy, again, I have to thank Dr. Maria Winter-Wasik, who developed our stereotactic radiosurgery program and our lung stereotactic program for this slide. The holy grail of radiation therapy is the precise delivery of radiation to the tumor while sparing the maximum amount of healthy tissue from inadvertent radiation. Now, this requires that the margins around the tumor are minimized, so it really requires precision and accuracy of targeting. And so radiosurgery fulfills this criteria. So radiosurgery is the delivery of one dose of stereotactic treatment. Fractionated stereotactic radiation, this is for the brain, which is called SRT, is delivery of multiple doses. And again, for the body, we call it stereotactic body radiation. And again, all these principles were first developed in the brain. And you can see why, because for single treatment, you're actually fixated into a device so you can't move. You know, your head is in this BRW head frame, and the radiation is actually delivered originally, and this is the original gamma knife. This is the prototype that was developed in the 1950s in Stockholm. And in Sweden, they actually developed some of the early use of stereotactic body radiation therapy as well. And this is really a standard of care, single fraction SRS for salvage for recurrent metastases, while, and receives a local control of about 85%. And it's also done as a boost to single metastases immediately after whole brain radiation. In certain patients, especially melanoma patients, renal cell cancer patients, will actually sometimes won't do the whole brain radiation if there's just a couple of solitary sites of disease. We'll consider only SRS. Again, it's typically not done routinely, but in certain situations, and melanoma is typically one of those situations, we'll consider doing just SRS alone for limited numbers of brain metastases. And these are ways that you can deliver the stereotactic. So this is the gamma knife. You know, it's multiple cobalt beams aimed at the target. And again, this is the fixation device. So again, you can't move, and this is the equipment. But there's other ways of delivering radiosurgery as well. And these other devices are actually used for SBRT as well. So one is the stereotactic linear accelerator. Again, patient fixation, very important. And then the patient treatment as well. And again, this is just an example of a patient getting treatment. Patients will get treatment with multiple different directions with this. So again, how can you know, it's easy to hold the head down. Either it's fixed, how do you hold the body down? And that's now that we have ways of sort of taking into account patient motion and other things, we can now do the same types of treatments for tumors elsewhere in the body. And this is the cyber knife, which is a miniaturized linear accelerator on a robotic arm. And again, has predetermined sites where it can deliver the radiation. This is a proton unit, so you can also do stereotactic radiation with a proton unit. And there's multiple other ways. There's TrueBeam from Varian, there's the Novalis. The important thing is that the brand doesn't always matter. It's the principle of the treatment, and you want to go somewhere where they abide by the principles of the therapy to get the treatment. But I don't think there is any generic. You know. I think it's all brand name. So then what we did was, it was evolution of technology basically from brain, and then we switched to the lung. The lung was an area, it's easy to see the tumors, simply because they're surrounded by air, and radiologically, the imaging is good. So again, stereotactic body radiation. So what they started doing for patients with actually originally unresectable lung tumors, now we do this routinely actually for patients with limited lung metastases, is we do 5 to 6 weeks of standard treatment, but it's actually delivered now over 3 to 5 days. So you have the same dose of radiation that's essentially delivered in 3 days. So it's the delivery of a large dose in a few fractions or treatments. This results in a high biologically equivalent dose. In theory, if you're squashing the dose in just a few days, it's biologically more effective at killing the tumor. But to minimize the side effects, it requires a high conformance of the dose to the tumor and rapid dose fall-off. And again, this requires appropriate immobilization, i.e. keeping the patient or the tumor still. You have to be able to see the tumor, and you have to do what's called image guidance. You know, what if the tumor moves out of the way of the radiation field? You're going to miss it. So basically, when you do these high-dose treatments, you actually stop the treatment in the middle, or re-image and make sure the patient is still in the right position, then continue the treatment. At least that's what we do. And also motion management. How do you stop the tumor from moving or the patient from moving? Now, you also, because of this, it requires appropriate patient selection. You actually have to be fairly fit for this. The treatments are long. You know, it's easy to treat somebody who's sick very quickly. We're not too sophisticated. We put a big area around the tumor. It also depends on the tumor size and location. If the tumor's too big, we can't do this. It's like, we can cause too many side effects. And its ability to tolerate lying still, the treatment can take 30 to 60 minutes. You know, we have to image before we do the treatment. We start the treatment. We stop in the middle to make sure everything is still okay. Then we complete the therapy. And we've had some issues with, you know, patients having trouble lying still. We do sedation. We'll give, you know, pain meds, sedation, you know, before the treatment. And multiple sites can be treated. Now, what we tend to do at Jefferson is we don't treat multiple sites at the same time. We tend to do one site, then another site. So if somebody has 2 lung metastases, 1 on each side, we'll do one week, and we'll do 1 the next week. Safer for the patient. It's easier for them. It's also safer for us. You don't make a mistake. You don't accidentally treat one side versus, the other. Although we hate to admit that, mistakes can happen. But it's a little bit safer. And by, waiting 1 week to treat the second tumor, you're not really hurting the patient. So this is standard treatment, 3D or IMRT versus stereotactic. This is from the Association of Physicists in Medicine Task Force. So what they basically say, standard treatment is typically 10 to 30 treatments. SBRT is typically 1 to 5. And occasionally we'll do the same principles. If we find the tumor's a little bigger, doesn't mean you can't have the same principles applied to you, but we'll do 10 treatments instead of 5, and the dose is lower, so then the risks become less. The margin is just a few millimeters, so we basically only put a few millimeters margin, meaning extra space around the tumor. And again, we have to have strict enforcement of our targeting accuracy. We have to make sure we're hitting the right spot. And if we're not sure, we don't do the treatment. Again, we don't want to take a chance, we don't do the treatment. And the need for respiratory management, again, this started in lung tumors move, you're breathing. So we have to make sure that if the tumor's moving, that we're covering the entire area can move. And again, we don't understand what the effects are. We know that the tumor appears to die, but what about late effects? What about other side effects? Because this is a newer technology, we don't have all that information. Now we're actually finding out that there's probably more side effects than maybe we originally thought with this treatment. Now, for lung cancer, we have data on both treatment of primary tumors and metastases. Interestingly, primary tumors tend to respond better to this large single high-dose treatment. Maybe it's simply because metastases often have mutations, so they don't respond as well to other therapy. The local control of metastases is dependent upon the dose, the size of tumor, but most reports for metastases note about an 80% local control rate at 1 year, so meaning that they don't grow or they're gone. Primary lung tumors typically have about a 90% local control rate. And actually, in elderly patients, this is often a primary treatment now instead of surgery. In patients who can't tolerate surgery, they'll often go ahead. And I should mention that we talked about lung metastases. Most of the patients we treat with SBRT for lung metastases, they've seen, we work with the surgeon. They've seen the surgeon, they don't want surgery, they're not surgical candidates, so they come for radiation. Or they don't want to do surgery because it'll interrupt their systemic treatment. It's a much longer recovery time after surgery than for radiation. So again, as Dr. Warner was saying, it's a lot of fuss over a few treatments. It's potentially highly effective, but it's a lot of fuss because it's also potentially extremely dangerous. Again, we can miss the tumor. You can hit a structure that could be very sensitive to radiation. And our assumption for SBRT is that a little dose to a lot of normal tissue is better than a lot of dose to a little normal tissue. So what you're doing is you're spreading around the radiation dose. This is a lung tumor. You're spreading around the radiation dose as opposed to concentrating it here. So again, 12 or 15 radiation beams. And you're assuming that this low dose is fine. But what we found out is that actually sometimes that low dose isn't good, that patients are still getting pneumonitis or lung inflammation related to this very low dose of radiation. So now we know that this very low dose of radiation has to be a certain percentage of the lung can't get any radiation. And again, this is actually a 4D CT. This is how we actually scan patients with lung treatment, and also for abdominal tumors. We actually do CT scans during respiration. And so they get a series of 10 CT images during various respiratory phases. And this is just an example of the 4D CT that we use for planning. So it shows you, look how, it's a lung tumor, look how much it's moving. So what we do is we measure how much it's moving, and we include that in the margin. The other option is you have the person do what's called breath hold or respiratory gating, which is where you take into account the motion and you trim your margin down accordingly. And this is, the images of the CTs that we use to outline the area of the treatment. And this is actually how the patient is fixated. They're basically in a body frame. This is called a body fixed device. This is actually a paddle for the lung patients that's put over their abdomen to remind them not to take a deep breath, because if they take a deep breath, the tumor is going to move more. And we also can use the paddle for upper abdominal tumors. So some people will, you put a little bit lower and you can use it to stop motion of the liver if you want to do liver SBRT, for example, or for pancreatic or periportal lymph nodes. So this is, again, is a breath hold and gating. So if you can try to get the motion contained, you can actually reduce side effects. And this is gating where they turn on the beam when they see the tumor. The beam is turned off when the tumor is not seen. Now, all this requires what's called image-guided radiation therapy. So SBRT requires what's called image-guided radiation. That's what I talked about. We have to see the tumor before we start the treatment. We possibly image it in the middle, and then we also do a verification, often at the end. Although I always wondered, why do we do it at the end? It'd be nice to know that, maybe we really don't want to do it at the end, but we still do it at the end. So this is external beam radiation with positional verification using imaging prior to each fraction. The treatment unit must have software that allows registration of the images, and it calculates the shift. So what we do, we have what's called a cone beam CT. We do a mini CT. It's fused with actually the treatment planning CT. I'll show you an example of it. And then the patient's automatically moved so the images match up. And it's a complete process that starts from the time of simulation. So this is an example. So this is an example of what's called a cone beam CT. So this is the localization, and this is the treatment. So it's 2 CT scans. This and this is from one CT, this and this is in the other, and it actually, you make sure, and this is a quarter image, that the tumor's in the same spot. And again, remember, because of motion from breathing, it's not necessarily going to line up 100% regularly. So this is called a cone beam CT that we, again, check to make sure that the tumor's in the right spot before we start the treatment. And again, we have to respect the normal tissue constraints. So for a lung tumor, we'll give 60 gray, which is a big dose, 60 gray in 3 to 5 treatments. Well, in the abdomen, we can't do that because the bowel is there. The bowel is very sensitive to radiation. And if you treat, for example, lymph nodes near the bowel, you could cause an ulcer and the person could bleed to death. But in the liver, you can do this. If you have a centrally located tumor in the liver, you can treat to the same dose because the bowel is away from that portion of the liver. So it's very important to respect normal tissue constraints, and that's why we usually recommend that people go somewhere where they have an SBRT program sort of already set up, where because again, you have to be very careful with this. And again, we've discovered, especially from the lung data, that they have found increased side effects that were unexpected. So in the lung, it's the esophagus, the bronchus, the pulmonary vein, the lung, and the chest wall, and the skin. And again, unusual toxicities. What they found is patients have persistent pain when the ribs get a very high dose of radiation. It's funny, we use a very high dose of radiation to treat tumors, but when the ribs get a high dose of radiation and there's no tumor, they actually get sore. The muscles get inflamed. So there's this incidence of chest wall pain and also rib fracture from the high dose of radiation. So now what we've done is we've modified, instead of doing 3 treatments in these patients, we do 5. And by cutting down the dose per fraction, we hope that you'll decrease the risk of the rib fracture and the thoracic wall pain. And what about SBRT for spinal metastases? That's another area that's received a lot of press lately. And this is just an example of SBRT for the spine. This is a standard treatment. This is somebody with the spinal metastases. Usually we treat 1 field from the front, 1 field from the back. You can do 1 dose up to 10 doses is standard. With SBRT, you typically only treat the vertebral body, which is this part here. This is vertebral body. This is the spinal canal here. And this is where the spinal cord sits. And this is the back portion of the vertebrae here. And what we do is we only treat this area, and it can get a higher dose. What limits the dose that can be received is the spinal cord. And so you have to select the patients for this very well. You cannot have a tumor that's too close to the spinal cord, otherwise you run into risk of long-term side effects. Now, why do we consider spine SBRT? Again, same principles as lung, just a different area. But it's most often done for patients who've had prior radiation. Just like we often send patients to Dr. Brown for ablation of bone metastases if they've had prior radiation. It's often done for patients who've had prior radiation. The rationale for considering it up front is really to improve pain control and decrease acute side effects. If you do the single treatment, there's sometimes less side effects. The esophagus or the swallowing tube lies in front of the vertebral body. Often that may not get too much radiation. And there's actually a current ongoing randomized trial, the RTOG 0631, which looks at 8 gray in a single fraction, which is considered a standard sort of quote-unquote palliative dose, versus a more ablative, right, ablative, meaning, try to kill the tumor better, dose of 16 gray. And to go on the trial, though, it's a little different because I know we've seen patients who have tumors that look like they may encroach, and we've referred them for treatment. In this study, you have to have pain. And that's the issue, is that it's hard to tell if the tumor is responding in the bone because the bone always looks a little abnormal once you've had tumor there. So to go on the trial, you actually have to have pain because they're using pain as the endpoint, one of the endpoints of the trial, as well as a quality of life looking at side effects. And again, there's less acute side effects versus a 2-week course of treatment. Again, note late effects, the risks of myelitis, and also risks of vertebral fracture. Some of the early studies looking at SBRT for spine showed an increased risk of probably vertebral fractures. And luckily we have people in interventional radiology that can help us out by putting cement in the bones to help stabilize, which is true. We have sent patients as well when we're worried about beginning of a compression fracture for treatment. And again, current data with SBRT indicates about a 70 to 85% improvement in pain and about an 80 to 90% local control. But, take this meaning, it's hard to tell what local control is since the bone always looks fairly abnormal. And I should tell you that 70 to 85% improvement in pain, standardly we see about a 50 to 70 to 75% improvement in pain using regular radiation techniques. So we're not talking that this is it's really the long-term improvement that we're looking at. The assumption is that using this, as opposed to a 3 to 6 month improvement in pain, we can actually prevent the pain from coming back or from getting worse. How about other sites? So many other sites can be treated as long as the principles of the therapy are applied. The liver is actually a fairly common site. Intra-abdominal tumors, recurrences, lymph node recurrences. I've treated patients with lymph node recurrences in the chest. And again, it's often used as retreatment. And just for an example, I treated one of Dr. Sato's patients with actually a primary with a lymph node metastases. She wasn't a good candidate for SBRT standard fractionation because the lymph nodes were right by the esophagus. So she actually got 10 fractions of treatment, had very few side effects, and was controlled there for quite a long time. So again, SBRT provides excellent local control as well as pain relief for the bones. You need to be cautious about the appropriate selection of patients. The dose is dependent upon the treatment site, and we need to be aware of the potential for new or increased side effects, especially late effects. And currently, clinical trials are ongoing. There was a trial for liver metastases that recently closed through the radiation oncology group. And the important thing to remember, it's a high-tech, non-invasive treatment with a minimum of visits, with a high expectation of success and low toxicity. And hopefully, we can keep this true. And I wanted to thank Dr. Maria Warner-Wasik and the physics staff at Jefferson for many of these slides. Thank you. And this is just a standard.